Hi everyone, I'm Robin Fales, Senior Education Associate at the Center to Advance Palliative Care. Welcome to today's webinar, the National Palliative Care Registry, Latest Hospital Trends and Insights. I want to remind everyone that the recording of this webinar will be available to CAPC members in CAPC Central, and we will also post it on capc.org for non-members. Before we begin, we want to welcome you to join us for upcoming virtual office hours and webinars. A calendar of these events can be found on our website and capc.org. Before we introduce our presenters, I want to let you know how you can participate in today's event. In the upper right-hand corner, you can see a control panel. By clicking the orange arrow, you can open and close your control panel. After our presentation, we will be hosting a Q&A session. We encourage you to type in questions and comments using your questions pane on the control panel. Simply type in your question and click send, and we'll do our best to get to as many as possible during the Q&A. Now, it is my pleasure to introduce today's presenters. Tamara Dumanovsky joined CAPC in November of 2014 as VP for Research and Analytics. With a strong background in public health research and program evaluation, she has extensive experience in applied research, evaluation design, survey development, and data analysis. Tamara received a doctorate in sociology from New York University. Maggie Rogers joined the CAPC team as a senior research associate in February of 2015. Her background in quantitative research and interest in chronic disease and cancer led to a natural progression into the field of palliative care. Maggie holds a Master's of Public Health and Epidemiology from Rutgers University and a BA in Psychology and Gerontology from Ramapo College in New Jersey. Please join me in welcoming our presenters. Tamara and Maggie, take it away.
Thanks very much, Robin. We're happy to be here, and we're very excited to be able to present some of the latest findings from the National Palliative Care Registry. So what we're going to do is go over some trend data and look at some insights for the 2015 registry data. As some of you know who have participated in the registry for many years, we did add several questions in 2015, so we're happy to have this opportunity to share some of that data with you. Robin, can you move the slide? Thank you. So the National Palliative Care Registry is a joint project of CAPC, the Center to Advance Palliative Care, and the National Palliative Care Research Center. As you know, it's a central resource for comparative data, reporting, metrics, and we've recently expanded a lot of the materials on the publicly facing site. So we have a lot of information on recent research on the composition and operations of palliative care programs. It serves palliative care programs across service delivery sites, and it's free and open to all programs. So through 2014, we were collecting data just from hospital-based programs, but in 2015, we expanded to include outpatient clinic office, home health, and long-term care. So now people who are delivering palliative care at those service settings can also enter data into the registry. And another thing that's important to remember, it's a joint project of CAPC and NPCRC. It's a free resource for users. You do not need to be a CAPC member to participate in the registry. Oops. Sorry, now that's me doing that. So the national participation rates in the registry, we looked at data from 2013 to 2014. This map shows you all hospitals that report having a palliative care program to the American Hospital Association, and those are all the green dots. Where the dots are purple are participants in the registry, and the size of the dot is the relative size of the hospital. So overall, 25% of hospitals participate in the registry, and 40% of programs at large hospitals are participating in the registry. I think there might have been we're going to look at some of the key findings and some of the trends from 2008 to 2015 right now. There might have been a pop-up poll here, Robin.
Sorry, what was that, Tamara?
I thought that there was a poll asking people who they were.
Oh, yes. We can run that right now.
first thing we want to know is find out who all is listening in. We have about 300 people on the webinar right now, so we're curious to hear who's in the audience. So if you could just take a minute and select who you are. If you're a palliative care team member, if you're a health system administrator, if you're another kind of healthcare professional, someone involved in research or policy, consultant, self-employed, or some other profession.
We'll give people another few seconds to answer. I'll go ahead and close it and show us the results.
Great, so we have 61% that are palliative care team members, but we also have a good representation from system administrators and other healthcare professionals. So it's good to know. We can keep on going with the slides. Key findings. I'm going to try to move this. Okay. Maybe one thing to understand from this presentation is that the data presented here are for hospital palliative care consultation service. We are excluding data from this presentation for palliative care units. So that would be, we have collect separate data for palliative care units in hospitals, and we'd be presenting some of that summary data elsewhere. So the first thing that we're going to be looking at here is palliative care service penetration, and this is a measure of how well programs are reaching patients in need. It's calculated looking at the number of initial consults as a percentage of total hospital admissions. So you can see that there's been a steady increase among registry participants from 2008 to 2015. Programs entering data into the registry, their service penetration has increased from 2.6 to 4.8 on average. The range goes anywhere from less than 1% to all the way up to 22%. Some projected estimates of what's the best fit for this measure is between 5 and 8% of hospital admissions, so you can see that these numbers are climbing steadily towards that. The next thing that we're going to look at is staffing levels. So two things that the registry collects. We look at head count, which is across all disciplines and titles, so total number of people that are part of the palliative care team, and then convert that into a full-time equivalent. So you can see that there's been a steady increase in headcount and corresponding increase in FTEs for palliative care teams. It's leveled off in the last few years. The latest data point for 2015 has a total headcount of 8.7 staff, representing 5.4 full-time equivalent positions. Looking at the Joint Commission staffing recommendations, they define a full core interdisciplinary palliative care team to include a physician, a nurse, either an APRN or RN, a social worker, or a chaplain. So we looked at the registry data to see what proportion of programs have staffing at this level. You can see it's gone up from 30% in 2009 up to 44% in 2015, but that still leaves 56% of programs that do not have a full core interdisciplinary team. Another measure that we look at is time from admission to palliative care consult. This slide is a little busy, so let me just orient you a little bit to the slide. We separate out live discharges from patients that died on palliative care in the hospital, and it's about 80% live discharges and 20% deceased. The two lines are mean time from hospital admission to consult and median time for those two populations, and we're looking here at 4 years of data. So you can see that the average time from admission to discharge has dropped slightly for both groups. For live discharges, it was 5.6 days in 2012. It's gone down to 4.9 days in 2015. It's important to note that about 20% of programs report a mean time to consult of less than 3 days or less. So we know that the earlier patients get a palliative care consultation, the better their outcomes are. So this is an important metric to track. for patients that eventually die in the hospital, they're being seen a little bit later in terms of the time from their admission to their first palliative care consult. This second slide looks at consult to discharge. So you can see that after consultation, patients who are discharged alive are leaving a little bit earlier. So it was 6.4 days on average. Now it's down to 5.6 days. And 30% of programs report a mean time to discharge of 4 days or less. So now we're going to look at some of the key findings for hospital palliative care programs. And we do have a poll question here before we start. So we want to know, for those of the 61% of you who said you were part of a palliative care team, where do you provide palliative care? You can check more than one of these options. So we're curious to know how many of you provide palliative care in hospitals, how many are in outpatient clinics, home health or hospice, long-term care, or some other service setting.
We'll give it just a few more seconds to enter your answer. Go ahead and close it down now.
Okay, so a lot of you are hospital-based providers, and we see that, I mean, this is consistent with the data that we find 30%. It's probably also outpatient for the hospitals. We see a strong showing for home health, which is great. We are, I hope you all are aware that we are expanding the registry to include home health, and we have a full survey now for home health. We also have an abbreviated survey for long-term care and for outpatient clinic practices. So we're hoping that you take advantage of the registry and start entering data and getting out reports for yourselves. So the next slide.
Okay, so I'm going to talk about some different features of palliative care programs. There are a few different models of palliative care that exist. The first is a consult model. Typically, the consultation team provides recommendations to the primary attending physician. In that case, the goal of the palliative care consultation service is to support the referring provider, and that's called the consult-only model. Other types of palliative care models include the primary attending. That's when the palliative care team assumes primary responsibility for the patient's care. There's also co-management. That's where the palliative care team partners with the primary providers to provide care for the patient. Typically, they assume care for particular clinical issues. There's also the mixed model. In mixed models, this is where the palliative care team assumes different roles depending on the patient's needs, the referring provider's needs, capacity, setting, and the team's approach can also change as the care needs change. So 61% of programs reporting to the registry are consult only. The rest are primarily a combination of consultation services and co-management. But things like primary palliative care, that's very rare from the programs that submitted data. So 24/7 coverage is defined as Monday to Friday inpatient consultation availability and 24/7 telephone support. Patients, families, and hospital staff need palliative care services that are available for both routine and emergency services. And you can see here about 46% provide 24/7 coverage. That means that more than half of palliative care programs, they do not have 24/7 coverage at this time. Team meetings, so 64% report having weekly team meetings where all of the palliative care staff are present. There are also a few of the other options include having weekly meetings where not everyone is present or having bi-weekly meetings or meetings as they arise. For recruiting of staff, 64% of palliative care programs are recruiting additional staff, and the majority of those are recruiting clinical staff, or they're going to be requesting new lines, new staff lines for clinical staff as well. So on this slide, this is the percentage of programs reporting each discipline as part of their team. So quick orientation to the slide. The green bar represents the percentage of programs that have funding for each discipline. This could be for any amount of full-time equivalent, or FTE. The orange bar shows the percentage of programs that have in-kind staff for each of these disciplines. So as you can see, if you look at the green bar for the APRN and the physician, you'll see that over 75% of programs report having funded APRNs and or funded physicians. But if you go all the way down to the bottom, you'll see only 4.4% report having funded pharmacists on their team. But now if you look at the in-kind, which I said is the orange bar, you'll see that the programs across the ones that report the in-kind staff, chaplains and social workers are the most common. So almost 20% of programs report having in-kind chaplains and 10% report in-kind social workers. So now we're going to talk about palliative care and hospice integration. I think we skipped a slide. Yep. Okay, so first we're going to talk about integration with ICU and emergency departments. So this is a check all that apply question in the survey. So programs can click more than one answer. So if you're wondering why it's not adding up to 100%, that's why. So this is the percentage of programs reporting the following things. And the numbers on the right side are for the ICU, the intensive care unit, or the emergency department. So 40% in the ICU and 44% for the emergency department report that they have no formal coordination. That means that while they see ICU or emergency patients, there's been no work to develop a system of care coordination between the ICU or emergency medicine department and palliative care. 48% and 48% for ICU and 18% for the emergency department, they say they work collaboratively. So that means that the palliative care team and the ICU or the ED teams, they work collaboratively to develop a system to enhance care. Examples of these things could be like putting in a screening criteria or having automatic consults from the ICU or from the emergency department. 17% and 4%, so 17% of programs and 4% of programs report that there are plans in place for palliative care with these departments. And what that means is that the ICU or the emergency medicine department have developed or implemented plans to improve delivery of palliative care. Examples of those include palliative care training for intensive care unit or emergency medicine staff. Maybe the departments provide patient and family support materials. Perhaps one of the departments hired a hospice or palliative medicine trained physician. And something else could be integrating routine family meetings into the ICU or into the ED. So now we're going to talk about hospice integration. This is also a check all that applies, so it probably adds up to a little bit over 100%. So 13% of programs report that they are one administrative entity with hospice. So that just means that the palliative care program and the hospice program function as one thing in the hospital. 35% are administratively separate. So that means that the hospital or the health system owns its own hospice, but it's administratively separate from the palliative care program. 32% have contracts in place with one or more community hospice agencies, and 39% informally collaborate with community hospice agencies. Okay, so in the earlier slide, we showed some of this data over time. Tamara showed from 2012 to 2015. So here is a deeper dive into the 2015 data. So for this slide, we're talking about patients that are discharged alive from palliative care. So they end up going home or they go to other locations after leaving the hospital. That's about 80% of palliative care patients. So here we're going to break down the time to consult in blue and the consult to discharge in green by the different hospital sizes. Overall, the average time to consult in 2015 was 4.9 days, and the average consult to discharge time was 5.6 days for patients discharged alive. So if you look at this graph, you'll see that in smaller hospitals on average, they have a time from hospital admission to palliative care consult of 3.3 days compared to 5.8 days for larger hospitals. So that means that these smaller hospitals are able to provide palliative care consults much faster than in larger hospitals. We also found that 30% of patients are seen within 1 day of admission, and 65% of patients are seen within 1 day of referral to palliative care. So if 65% of patients are seen within 1 day of referral, but the overall time from hospital admission to palliative care consult is 4.9 days, this may reflect later referrals to palliative care by the hospital. 7% of palliative care patients are not able to be seen before being discharged from the hospital. So this is the same slide that we just looked at, but instead this is for the patients that die on the palliative care service in the hospital, which represents about 20% of patients. It's a very similar pattern where the smaller hospitals are seeing patients much quicker, and the larger hospitals are not able to see them as quickly. But overall, compared to the patients that are discharged alive, the time to consult as well as the time to discharge are much longer for patients who eventually die in the hospital on palliative care. And because the data, as Tamara mentioned earlier, because the data is very different for the two groups, we separate these out. So now let's talk about where are these patients going. So once they're discharged from the hospital, where are they going? So as you can see, 80% of palliative care discharges, as I mentioned earlier, are going to be discharged out of the hospital. If you look at the different categories, in purple is home, in the orangey yellow color is a skilled nursing facility, green is non-home hospice, and the blue is other locations. So you can see that the discharge locations are generally similar and consistent across hospital sizes. The largest difference is in the skilled nursing facilities. So for those, smaller hospitals are discharging a larger percentage of patients to skilled nursing facilities. So on the left, you'll see the 28% in yellow, compared to larger hospitals where only 19% are going to skilled nursing facilities. So overall, 38% of patients are discharged home across all the bed categories, 24% are discharged to skilled nursing facilities, and 17% are discharged to non-home hospice. Example of the blue bars, the blue sections, that represents other, and others can include things like acute inpatient rehab facilities, long-term acute care hospitals, general hospital, either getting admitted to another section of the hospital you're currently in or being transferred to a secondary hospital, residential care facilities or assisted living facilities, and then any unknown or other locations that weren't specified. So patients are discharged to assisted living and residential care facilities, but that only accounts for about 2% of discharges. You could add that to the home number, and you would get 40% of patients being discharged to home, either a residential home or an assisted living facility. So this is one of the new questions that we added to the registry. We're trying to get at what percent of the palliative care patients were readmitted to the hospital within 30 days of discharge. In the blue is the mean, that's the percentage of patients, and the orange is the median. So across all programs, the average readmission rate is 14%, and the median is 11%. There is some variation by hospital size, but as you can see, there's no consistent pattern. So there's not really a direct relationship between the size of the hospital and the readmission rates for the palliative care patients that are discharged. So let's talk about some symptom management. So here we're going to talk about screening for pain and dyspnea. Dyspnea is difficult or labored breathing. So in the survey, these questions are sequential. You can kind of see by the way they're outlined. So percent of patients screened, if positive. Almost all of the patients that are screened for pain, almost all patients are screened for pain and dyspnea. So you can see 94% of patients are screened for pain and 90% are screened for dyspnea. On average, just over half of patients screen positive for pain, and just over 1/3 of patients, they're going to screen positive for dyspnea. So of these patients, the ones that are screening positive, Most are receiving a clinical assessment for pain, or they're receiving treatment for dyspnea within 24 hours. So 95% are receiving a clinical assessment for pain within 24 hours, and 82% are receiving treatment for dyspnea within 24 hours. 70% of patients report pain improvement in 48 hours, and 52% of dyspnea patients report improvement, also in that same 48-hour period. So now we're going to talk about where these programs are getting their patients from. So where are the palliative care referrals coming from? This section is going to be about the hospital unit, or we can say the patient location at the time of the referral. So where was the patient in the hospital when they got the referral for palliative care? There are 10 different categories. We chose to report the top 5 here. So this is the top 5 referring hospital units. Smaller hospitals have a larger percentage of patients coming from the medical surgical unit. That's the one that you'll see in blue. For small hospitals, about 49% of patients are coming from med-surg. In large hospitals, the 500-plus beds category, 37% are coming from the med-surg. And then larger hospitals, they have a larger percentage of patients coming from the ICU. That's the orange bar. You'll see that in small hospitals it's 23%, and in large hospitals it's 29% from the ICU. And large hospitals are also seeing a larger percentage coming from oncology. That's the purple bar. So 5% in small hospitals, 13% in large hospitals. And the other ones don't necessarily show a very consistent pattern across the bed sizes. But overall, for all hospitals, 41% of patients are coming from med-surg, 26% are coming from the ICU, 9% are coming from oncology, 3% are coming from the emergency department, and 12% are coming from the telemetry or step-down unit. So next is the referring specialist. So this is who's referring these patients for palliative care. So in the blue is the hospitalist, orange is oncologist, purple is an internal medicine specialist or an internist, pink is a pulmonary or critical care specialist, and the green is the cardiologist. Again, there are 10 categories, but we chose to report the top 5 to keep it simple. Some of these patterns that you see in either the unit or the specialist are likely to reflect the organizational and staffing structures of the hospital. As you can see, most referrals are coming from hospitalists, and it's much larger in smaller hospitals. That's probably because the majority of smaller hospitals' referrals are also coming from the med-surg unit. There's also more diversity in referring physicians in the larger hospitals. So because they're seeing a smaller percentage of patients coming from hospitalists, they're seeing a larger percentage from other disciplines. Overall, 48% are coming from the hospitalists, 7% are coming from oncologists, 10% internal medicine, 13% pulmonary critical care specialists, and 4% from cardiologists.
Oh, so now we have another polling question. Oh, I'm sorry. The slides are moving themselves. I apologize for that. Robin, can you help us get to the satisfaction survey slide?
Yes.
Thank you.
Okay, so before the poll, we're just going to quickly share one of the last things from the 2015 data that we're going to talk about, and that's patient and family satisfaction. So as you can see, only 38% of programs report surveying patients and families for satisfaction of their services and their care. But of those, 77% are using a standard instrument. Their average response rate that they're getting back in the survey, so the percentage of patients that got the survey that are then responding to it, is about 20%. And there is no major differences by hospital sizes. Smaller hospitals are not less likely to have one. Larger hospitals are not more likely to have one. It's kind of spread around who is doing the patient and family satisfaction surveys. Now we can do the polling question.
And now the polling question is not there. Robin, can you pull that up?
Yep.
So we'd love to hear, after kind of people learning what the data are in there. We just reported on a lot of the data that you have entered into the registry, and we really appreciate your participation. So we'd like to know who out there has participated in the 2015 National Palliative Care Registry. So the answers are yes, you did, no, but you've participated in the past, no, but you plan to, and you can always participate. You can still add your 2015 data. No, you haven't participated, or you're not part of a palliative care team. So that's great that half of the people on the call are people who have entered data in the 2015 registry. So a lot of this is familiar to you, and I hope to the rest of you that we've been able to explain some of the data and resources that are available in the registry. We want to take a few minutes just to talk about the redesign for those of you that are not familiar with it. So that, going to pop to the next slide. Okay. So the registry was redesigned, and we launched it in March 2016. It's more accessible. It's easier to use. Each program now has a dashboard that's really interactive, where they can get access to a lot of reports immediately. They can also get access to all of their historical data. That's something that we didn't offer in the last version. They can enter and edit or update data at any time. And as I mentioned in the beginning, we're expanding to other service settings, which are outpatient clinics, home health programs, and also long-term care. Programs now who go to any of these service settings, or to more than one of these service settings, can use the registry and enter their data by service settings, so that we can get a landscape, a picture of just the continuum of care for palliative care programs. So we hope in the coming year or two to be able to build up the same kind of resources that we showed you here for the hospital programs, to have similar data for the other service settings. Other new features in the registry are instant tables, graphs, and comparative reports. So you used to get a single report, you'd wait about 6 to 8 months and get one report, and you download a PDF. So now we have a whole menu of different reports, and you can get them at any time, and they're updated as you enter data. As other people enter data, comparative data will also be updated. So we have 8 longitudinal reports right now, and so you can look at your own program data from 2008 forward, and it basically focuses on staffing, penetration, length of stay, and discharge. We also have 9 comparative reports. These cover penetration, staffing, workload, and length of stay. So you're compared to other programs in terms of size of program, penetration quartile, and staffing quartile. We also have 4 comparative reports that look at longitudinal data. So we look at penetration, staffing, and workload by program size over time. And as I said, all of the data, as the data are updated, all of the reports get updated. You can also kind of do a request for multiple reports and get that downloaded and emailed to you. Other new features that we particularly like are the Invite a Colleague. So on your dashboard, you can automatically send an email to other people on your team, and they will get automatically signed up. They'll get an email asking them to set their password, and they can get instant access to the dashboard. So on the interactive dashboard, you have access to all the surveys, reports, and your own program information that you can update. You can also now download completed surveys. So once you've entered the data and you want a copy of the data that you entered, you can also just download a PDF of a completed survey. And there's a couple of other features that I want to mention that are on the public-facing website. So there's a lot of resources that are available at registry.capc.org. So you don't have to sign up for the registry. You don't have to be a participant in the registry, and you still have access to a lot of the summary data, extensive literature review on topics that the registry covers, registry publications, key definitions with calculations, the survey questions, and other features like this webinar will be posted to that site. And those are the kinds of materials that we hope that can benefit the field in general, and we hope that in looking at the data there, it'll encourage people to sign up for the registry. A few other things of note that we are currently putting together a summary, kind of 8-page report that's going to look at the latest trends and insights in hospital palliative care, and that's going to be in a PDF version. A health affairs article just came out in September, looking at issues around staffing and the need for more training and education for palliative care staff and just more numbers of staff. And as I just mentioned, that you can find a lot of summary data and relevant literature at the registry website at registry.capc.org. So that concludes our presentation. Robin, did you want to say anything?
Great. Thank you so much, Tamara and Maggie. We will now begin the Q&A portion. To ask questions, simply type your question in the questions pane and click send, and we'll do our best to answer them. So, Maggie, if you want to go ahead and read out the first question, you can go ahead.
We are just starting to look at the questions, Robin. So Maggie's just pulling one up right now.
So the first question is, could you clarify for me what is the difference between PQQ, QDX, and the National Palliative Care Registry? Tamara, would you like to answer this one?
Sure, I'm happy to. So the National Palliative Care Registry is aggregate data that's annualized. It's not patient-level data, so we're looking at structural and operational features and looking year-to-year changes and comparing the kinds of metrics that we looked at today across programs over time. QDX and PQRN are both quality improvement resources, so it's monthly or real-time patient data and looking at specific patient-level outcomes. So it's really, both of those programs are more like quality improvement collaboratives, where you focus on a specific area, make improvements, and also connect it directly to patient-level data. So they have distinct and I think very complementary resources. I look at the quality improvement collaboratives as very narrow, deep dives, looking at patient data and patient-level outcomes. The registry data gives you a broader context of how does your program fit and how's your program looked compared to other programs nationally. So it's very wide, but it doesn't go deep into patient-level data.
Okay, the next question is, does the 38% of patients discharged to home include home with hospice? And the answer is yes. So the patients discharged to home, we do collect, after we ask what location the patients are being discharged to, we do ask what services they are being provided. So when you say, okay, 20% of my patients are being discharged to home, we then ask what services they're being provided once they get to home. But one of the problems with that is we found that a lot of programs are not able to report this level of detail at this time. So hopefully moving forward, we'll be able to tell you what percent are being discharged to home with palliative care, what percent are being discharged to home with hospice, what percent are being discharged to home with self-care. But on that graph, the 38% being discharged to home does include going home with hospice. And the hospice category, that's going to be the location of hospice, so non-home hospice. Another question we have is, are we still able to enter 2015 data? The answer for that is also yes. You're able to enter your 2015 data at any time. We did have a deadline in order to be included in our summary analysis. So basically everything that we presented in this presentation, we did have a deadline in order to be included in this data. But you can, if you haven't had the opportunity yet to enter your 2015 data, you can still go in at any time and you can enter that data now.
Another question is asking about, do we track the average time from palliative care referral to the time initial palliative consult takes place? So we don't track that in absolute days the way we do mean days from admission to consult, but we ask what percentage of your palliative care patients were seen within 1 day of referral to palliative care, and that is the number that I think we presented on one of the slides. Which
yeah, so that number is 65% of patients are seen within 1 day of referral to palliative care. We can always, in the future, extend out that question further to get more data, but just as an initial touch to see how programs are able to respond, it is 65% of patients are seen within 1 day of referral to palliative care.
Next question looks at the FTE team. Were they internal or FTE dedicated to palliative care program? And that, Maria, that's your question, and I think what you mean is, are they internal to the palliative care?
So the answer to that one is that the FTE, if you're responding to the graph that's showing the 2008 to 2015, the staffing levels of headcount and FTE, those FTEs are any type of FTE reported by the program. So it could be internal to the palliative care program, so it could be funded. It could also be FTE that's dedicated to the palliative care team, so it could be an in-kind position as well. And this also includes volunteer. So for that FTE graph, in 2015, we had 5.4 full-time equivalent for a palliative care team, and that includes anybody or any funding for that program. So we got another question. The question is, I'm currently operating in a 2-person consultative care team. What can I use from the registry to demonstrate to my administration that it's worth it to expand our palliative care program and our team? So if you do enter data into the National Palliative Care Registry, Tamara did mention that we do have various reports that are available. These reports are going to be comparing your program to similar programs. So you can see how things like your staffing compares. And so say, for example, maybe a similar sized hospital to you, everybody has more staff than you do. That's the kind of report that you can take to your administration and say, hey, you know, everyone has so much more staffing than we do, like we should really be up there with them, and then we could be performing even better. We also do have a summary data table that's available on the registry website at registry.capc.org. If you go there, there is a 2015 summary data table, and that's going to compare staffing by hospital size. So you can see what percentage of programs in your similar sized hospital have things like a pharmacist, if you're interested in expanding your team to a pharmacist. And having comparative data makes it really useful when making arguments to administration.
And here's another question. I'll just read it. Is there a document available with a list of all data questions that are asked on the registry that can be used when collecting data to report? Yeah, so we have a blank survey that we have all the survey questions listed. It's on registry.capc.org, and it's under Participate, and you can get survey questions, and you can download a copy of the survey questions that you can just write on and then go to the registry and enter the data once you've collected all the data. The registry is also organized in terms of modules, so you can enter data in one of the modules and then leave and come back when you're ready to enter data in other modules. As long as you've entered enough data that's sufficient to generate one of the reports, then those reports will be generated. So you can always enter data at different times for different modules. You can also invite a colleague and ask them to enter data on a module that you might not be as familiar with.
We have another question. Do you have breakout data for pediatric palliative care programs? So we recently specified the registry to be a little bit more relevant to pediatric palliative care programs. This presentation that we gave, we excluded programs that are pediatric only. Programs were included if they see adults and children, but pediatric only were excluded. We're actually doing a push right now to have pediatric palliative care programs participate in the registry. We're hoping to get a higher number of participation, and then for pediatric palliative care programs, we'll be able to do a breakout webinar, we'll be able to do a separate summary report, a bunch of different things that would be available to pediatric palliative care programs. We just need a higher number participating in order to get to that.
So here's a question of what's the definition of in-kind, as in what's an in-kind chaplain. So the funding, when we look at 3 categories, they're funded positions, in-kind, or volunteer. The funded would be directly funded through the palliative care program. In-kind is they are funded elsewhere in the hospital, or they may have some outside funding and they come in as in-kind. So that's what we mean by that. Most of the non-funded positions are programs are reporting them as in-kind, and there's very few people reporting as volunteer positions. So it just means that they're not directly funded by the palliative care program. We're just reading through some of the questions right now. So the one question is, how many programs have consistently participated in the registry over time since 2008? We're surprised to see this number. So the number that participate annually is about 400, and there's about a 75% overlap from year to year. So I'm rolling away right now, but I'm going to get you what that number was. It's about 100 programs that have consistently entered data from 2008 forward. We're just reading through a couple of other questions and pulling one out. So we're both going to just read this question right now. So the question is, do you track % of patients enrolled in hospice within 24 hours of admission and CMS measure? No, we don't have that question now. This is something that we can add. And it reminds me that we do also, with the registry redesign, we are developing topic-specific surveys that we will be able to put out like 3 or 4 times a year. This question sounds like something that would be interesting to do a deeper dive into, and we would invite registry participants to complete like a short survey of 5 to 6 questions. The other place where this might be appropriate is looking at some of the other surveys that we have. But this is definitely, these kind of questions are really helpful, because if this is something that folks are interested in doing, we can always add questions to the registry going forward. So it says, are there any differences in patient outcomes, such as length of stay, for programs that have fully staffed interdisciplinary teams versus not fully staffed teams? So this is a question that's of huge interest to us, and these are the kinds of things that we are going to start to look at more closely with the registry data. Today we just presented you a quick overview without a lot of kind of cross-referencing a lot of the fields and variables. But this is something that we're really looking at in more in depth, and we should have some data on this in the near future when we present the trends report. And that's one of the areas that we're specifically looking at, is comparing full interdisciplinary teams to programs that have less than that. Maggie, do you see another question?
Yeah, lots of questions.
So there was one up here that was, hold it off until later. Which is this one? Obs beds not included in initial visits. So why are observation beds and ED consoles not included on initial palliative care visits? We got this question a lot, and for that reason, we wanted to get a count and estimate of how many programs are seeing how many patients in the obs beds and in the ED. The survey itself is specific to inpatient palliative care, so we wanted to be clear on that. But we do also ask you about, of patients that you see in observation beds and in the ED, how many of them are transferred to inpatient, so that way we're still getting at that denominator number. But we are keeping those populations separate.
Yeah, it's really important to exclude the observation patients as well as the emergency department patients that are not later admitted into the hospital out, because a lot of things like our penetration rates, which is so important to the registry and a lot of our comparative data, we really look at the penetration rates of your palliative care program, and we're not able to get that denominator of admissions because it does not include the observation patients and it doesn't include the emergency department patients. So if we were able to get a larger denominator that included non-inpatients that are seen by hospital, in general, we could do that, but for now, we limit it to the inpatient. If your program also sees patients in something like an outpatient clinic that's associated with the hospital, we actually have a separate survey for those patients.
So this is another question that comes up quite often, and it's like, how do we define admissions, and are you including observations, pediatrics, neonatal, and can you discuss the specifications for measurements of admissions, please? So we use the standard definition from the American Hospital Association, and in fact, when you open a survey and start to enter data for a hospital inpatient program, there's certain fields that are going to be pre-populated because we connect it to the AHA data, and one of those is admissions, and the AHA data includes all admission excluding newborns. Is that right, Maggie?
Yeah, so it's all admissions except for newborns. If there's a nursing home facility in the hospital, we also try to exclude that as well. But the only exception is if you are a pediatric-only palliative care program. In that case, you're going to be limiting your admissions to pediatric admissions, which can include newborns, especially if you're seeing babies, you're most likely seeing newborns. So unless you're doing pediatric only, the admissions is going to be excluding newborns.
The in-kind. Yeah. So the one person asked us, can we give examples of a standard instrument for patient family satisfaction? And we did not, but we're curious to know what people are using out in the field, and there's certainly recommended surveys out there. But we did not ask a specific question about what are you using. Again, this would be the kind of question that we'd want to learn more about, and we would probably do it in a topic-specific survey. But we can certainly get back to you, the person who asked that question, we can get back to you with some information.
Somebody asked, what's the national readmission rate? Because we showed you guys the readmission rate for the palliative care programs that enter data into the registry. We actually just pulled it today from CMS. And it looks like in 2016, the national readmission rate is between 17.5 and 18%. And this is a 12-month moving average. So that's what you can have for a comparison.
And that's all cause, right? All condition?
Yeah, that's all condition hospital readmission rate. Someone else asked if they can get automatic national comparisons when they participate in the registry. So does your registry automatically show you data relative to the benchmarks of national mean medians for things like time to consult? So in the registry, we don't necessarily provide what you would call benchmarks, but we do provide national means and medians. It doesn't necessarily mean that that's what your goal should be. It just means like that's where we are right now
as a field
nationally. And so yes, if you do participate in the registry, as soon as you enter your data, you're going to automatically have access to reports that are going to show you compared to the national means and medians for things like time to consult, penetration, staffing, a bunch of different things like that.
Workload,
exactly. So if you do participate, you will have access to that stuff. And as I mentioned earlier, we do have a data summary sheet. If you go to registry.capc.org, and on the top black navigation, you go to metrics and resources. The next section is called summary data. And there is a sheet that you can download, and that basically summarizes all of the data points that we collect in the registry by bed size. So you can use that document to look at what % of programs have Joint Commission certification and see what % in your bed size category are Joint Commission certified. So you can kind of see, okay, like only 14% in my bed size are Joint Commission certified, and we're not. So it's, we're pretty close to everybody else. So you can get that kind of information. It's publicly available on the website. Participating in the registry is only open to palliative care programs, but we try to provide additional data for other people like hospital administration, researchers, policymakers. Somebody asked if we're collaborating with the other palliative care registries. Tamara answered earlier that the differences between them, but we will be presenting at the CAPC National Seminar about the 3 different registries. We will all be there presenting together on the differences, the similarities, and the collaborations between us. And we will also be doing a similar presentation at the AHPM HPN conference in February in Phoenix, Arizona.
And somebody asked if we can directly enter patient data or do a batch upload. And right now, the data is collected annually, so we don't have any mechanisms to do a direct link. Some, I know that if you use Cerner, they are developing a direct report so that you could generate a report within Cerner if you are using their palliative care solution product, and you could generate a report within their system, and then you would still take that annual summary data and go to the registry site and enter the registry data there. So no, we don't have a direct link, but we do have the surveys that you can download to collect the data. And I know that some of the electronic health records are trying to develop tools that will help people use the registry.
Somebody asked us to repeat the percentage of patients that are not able to be seen before discharge by the palliative care team. That number is 6.8%. It's very similar across the hospital sizes. Smaller hospitals seem to have a little bit higher of a percentage, but it's 7.4% to 5.9%. That's the percentage that are not able to be seen by the palliative care team before discharge.
And someone is asking about the workload as it relates to the average daily census, and they asked about the average daily census on palliative care. We don't have a question. I don't think we will look more closely at our data. We don't ask a specific question on the average daily census and workload, but the workload measure is total. It's initial consults per each per one interdisciplinary team member, FTE. So it's per one interdisciplinary team full-time equivalent, so number of consults. So it's a number that's around, I think the average is around 225, if my recollection is right. But that's in some of the summary data, but we don't collect the daily census for palliative care, but that is something that we can consider adding in the future. So I think that we are, there's a couple of other questions that we didn't get to, but we will try to reach out to people and answer your questions directly. But we are coming to the end of the time, and I want to respect everybody's time, and we appreciate everybody participating. We hope that this was helpful to you and that you check out the registry website at registry.capc.org and consider, if you haven't already, entering data into the registry. And people who have already entered their data, all of your reports are available and are there. If you have any questions, you can always reach out to us. If you reach out to the registry help desk, either myself or Maggie will be responding to you, so you'll be talking to us directly. And it's all new and it's all a new launch, so any feedback and information that you guys can give us is going to be extremely helpful as we move forward.
And this presentation was kind of a preview for the upcoming trend report, which should be available at some time next month. So in that trend report, we're going to be showing some of the similar things that you've seen here, but even more than you saw in the presentation today. So everyone should look forward to the trend report when it comes out.
So thanks, everyone. We appreciate your time.
Thanks, everyone, for joining us, and thank you so much, Tamara and Maggie, for the informative presentation. And just to remind everyone, the recording and slides of this webinar will be available on CAPC Central and CAPC.org. Thanks so much, everyone, and have a wonderful day.